Well, good morning, everyone. I am Peter Christian. Joining us here in studio is Dr. Jeffrey Stephenson. He's a radiation oncologist with the Montana Cancer Center, which, of course, is situated at Providence St. Patrick Hospital. Jeff, good morning, sir. Welcome.
Yeah, good morning. Pleasure to be here.
Hey, before we launch into all that you do at the Montana Cancer Center, tell us a little bit about yourself, where you come from, your education, a little bit of your background.
Okay, sure. I grew up in Madison, Wisconsin, and went to university, medical school, and residency there. So the first 31 years of my life, I never left the same town. And then because of that, I moved to Florida for 13 years. So I thought, well,
what a nice change from Wisconsin to Florida.
That's right. I've been up north, so now it's time to try the south, and lived there for 13 years. Raised my kids pretty much in Central Florida. I was a Disney dad. We had our year permits and took that was our bribery for homework. You do your homework, you can go over to Disney World on the weekend, and it worked out successfully, getting the kids to study a little bit and things. And then 8 years ago, we got offered a job in Great Falls. They had built a new cancer center there, and we ski every winter. We bring the kids out skiing, and always loved the West. And we thought, is this really, the right move? I mean, are we insane? I mean, what are we doing here? But it was the best decision of our lives. My wife and I love it. We canoe, we hike, we love Glacier Park, and the kids were older. We did have our youngest finish school here in Montana, and it's been a great time. And then 2 years ago, the St. Patrick's group recruited me to move over here to Missoula, and we've been able to do some fancy new treatments with the new center, a lot of new equipment that they put in a couple years ago, and so it's very exciting to be able to offer some of these new fancy treatments that we're able to do.
And so now you're here to stay.
Now I'm here. Oh yeah, I mean, I've kind of been working my way west,
sure,
but I think I'll stop at the state line here. I don't want to go into Washington.
So what got you interested in working with cancer patients?
It's interesting. When I was a resident, there was something called the Geminic Report, which is initials, and I don't even know what they stand for, but it was 1983, and I was in my third year of medical school. And in the Geminic Report, they said their radiation oncology was a shortage area. And I thought, well, shortage area, that makes, and there are only about 3 or 4 shortage specialties. So I said, okay, a shortage, well, that sounds like that's got good job security then if it's a shortage area. So in my fourth year, I took an elective in it. I was going to go into anesthesiology and loved radiation oncology. So right before we have our match, they call it, where you get to pick your specialty, and the computer basically picks where you get trained. And I put in for radiation oncology and got that, and the rest is history. But it's a wonderful specialty, especially radiation oncology, because we treat kids, women, men, old people, young people. I mean, it's anybody. Unfortunately, anybody can get cancer, and so it's just the people you meet, the patients are just they're heroes, and I love them, and it's been the best job. You get depressed at times, you lose people you love, but we cure so many people, and you see the progress just in the last 25 years that I've been in practice. People used to get sick all the time. Now they're cured. Now they're walking around. Now they're walking in and out every day, getting treatment, working, going to school, whatever. So it's.
I was going to ask you what is the biggest difference between now and say 10 years ago, when as far as cancer. First of all, there's lots of different kinds of cancer, and there are many ways of treating it. Radiation is one, right?
Correct. Radiation is one. Chemotherapy, you hear a lot about chemotherapy, drug treatment. And, of course, surgery is usually the first step to remove the cancer and then look under the microscope and see how far it's spread. But I think quality of life is huge. With chemotherapy, with drug treatment, people used to be sick in the hospital, getting IV fluids, for just days and days and days. Rarely do we ever have to admit anybody now because they're throwing up. There's so many good drugs that controls nausea and keeps people healthy. Their blood counts, we can give them medicine that makes their blood stronger for chemotherapy, which we couldn't do 20 or 30 years ago. With radiation, we didn't have the precise treatments nowadays, so we had to treat larger areas. We didn't have the computer systems to be able to calculate the dose. So people were very sick, and there was a lot of side effects, and those have gradually gotten better and better each year, so that now many women and men who get treated, they don't even know. They ask me, "Are you even turning the machine on? I feel so good," which I guess maybe not good, but
sure.
I don't feel sick. I
Yeah,
don't really feel bad. So it's by being precise with the treatments and using these complicated computers that we're able to shape the radiation dose. It's very gratifying to see people not have a lot of side effects.
Now, with radiation, it is a targeted protocol, right?
Correct.
And so how do you figure out where to point that very potent tool?
Radiation is a little like surgery in that way. I mean, the surgeon, if you had a tumor in your breast, say, the surgeon's got to be able to go in and know where that is. So with the surgeon, they put a needle in the breast, using an X-ray, and they'll put a needle into the tumor. And that way, when the surgeon opens up the skin, he can go right down where the needle is and find the tumor. With me, we use CAT scan is the big one, but we also use MRI and PET scan. And but for our planning purposes, we use a CAT scan and we make a little model of the patient. We make a three-dimensional model of the patient, and then we can put the tumor in there, and we can decide what angles we want to use, how much radiation from different angles. Say we want to avoid the kidneys or we want to avoid the eyes, which we do. The computer basically tells us, okay, come in from the sides or come in from this angle, and you can avoid the normal structures, the vital structures, but you can get that radiation in where the cancer is.
What exactly does the radiation do to the cancer?
Well, it breaks the DNA. That's basically what it is. The DNA is how the cell divides, and so cancer goes crazy. Cancer is a cell that used to be part of your normal body, but for some reason it decides to go nuts, and it starts dividing uncontrollably. And while it divides, eventually it'll start to spread. Well, to be able to divide, that DNA is the information, the genetic information in the cell, and it has to divide. Cancer goes in and it just breaks. It breaks those strands of DNA. It just hits them, the radiation does, breaks the strand, and then the cell can't divide anymore. So that's how we kill the cancer and keep it from dividing.
So we're going to take a little break. When we come back, I want to talk about, there are several really cool acronyms here that I can't even pronounce, about 5-day treatment programs that I know we've done news stories about, quite literally on the cutting edge of what's happening in medicine right here in Missoula, Montana. So can we talk about that when we come back?
You bet.
Okay, if you have a question or a comment for Dr. Jeffrey Stephenson, he's here in studio. Happy to take your question, and if we can, we'll answer it for you, 721-1290, or you can make your comment on our Facebook page from KGVO. We'll be right back. And we're back on Health Talk, sponsored by Providence Health and Services, Western Montana. Dr. Jeffrey Stephenson joining us here in studio, radiation oncologist with the Montana Cancer Center. Now, I've heard, I did a couple of news stories recently about some really innovative technologies and treatments that are going on in the Cancer Center that are 5-day programs. Almost someone's like it's Nutrisystem, the 5-day diet plan. Tell us a little bit about some of these treatments.
You bet. Well, the big one, I think, is breast cancer. We know that most women are diagnosed early because they go out and get their mammograms. And all you ladies out there, get your mammograms every year and keep an eye on things. But we catch most breast cancer when it's just a half-an-inch size tumor. And so the majority of women will have a lumpectomy. The surgeon will go in, take out the lump of cancer, and then try to take out a little bit of normal breast tissue. We know that for early stage breast cancer, the area that the cancer cells might be hiding is just around where the surgery was. In the past, we used to treat the whole breast for 6.5 weeks, Monday through Friday, 15 minutes a day. It was very effective. You had about a 20 to 25% risk after a lumpectomy that there were some cancer cells there. If you took your radiation, you dropped that down to 5% risk. You're never going to have a 0% risk because you still have a breast there, and each breast has a 5% lifetime risk. But we can make you normal again. You do your lumpectomy and your radiation, and the cancer is very unlikely to come back. Well, because these early tumors, the area at risk was just around where the surgery was. Starting in the 90s, there's some centers around the country that said maybe we don't have to treat the whole breast anymore. Maybe we can just treat the area around where the surgery was, and because we're going to put the radiation inside the breast. They started with needles. They would actually stick needles into the breast after the surgery and then put the radiation into those needles and do a 5-day course. And the cure rate was identical to the 6.5 week course. Then in 2002, they developed a catheter that instead of a lot of needles, there's just one device that you put into the hole that the surgeon leaves behind. And that puts the radiation right in where the tumor was. And you can do twice-a-day treatments, morning and afternoon, for 5 days. And you put higher doses of radiation because you're putting it right in where the cancer is. But the radiation does not spread. It doesn't have a very penetrating type of radiation. So it just treats the area where the surgery was, and the cure rate, again, was very, very good. So this really has started catching on in the last 10 years.
Well, tell me the reaction from the patients. How are they dealing with this?
The patients love it. Women are working. They're like, I just really can't see doing 6.5 weeks. The big ones are ones who live 100 miles away.
Right,
and there's only so many hospitals in the state, and we're a huge state with long distances. So in the past, a woman might say, I can't go to Missoula for 6.5 weeks. I've just got to have my breast off, because it's just too much. Now it's like, okay, you can have your little lump taken out, and then a week later we put the catheter in and stay here in town for a week, and you're done. And women are like, yeah, I'll do that. And you heal quicker after a lumpectomy. With a mastectomy, you're going to be in the hospital overnight. You're going to have a drain coming out of you for 2 weeks. With a lumpectomy, usually you don't need a drain, and you go home the same day. And so it's a real, for quality of life, it's a real good option.
How do they get the radiation into the catheter? And are there any heavy metals involved that might be damaging?
There is. The isotope that we use is iridium-192. It's a radioactive seed, and it's in a robot, and the robot gets hooked up to this catheter, and the robot puts the seed inside the breast, inside the catheter, and it stays in there for maybe 5 minutes, and then the robot takes the seed of radiation out of the breast, and we unhook the lady and put a big heavy dressing over it, over the catheter exit site that's coming out of the skin, and then they go off into the wild blue yonder and come back 6 hours later for the second treatment.
Man, that's just amazing.
Yeah. It's a little grain of rice. It's just the size of a grain of rice, but it's called high-dose rate iridium-192, and we can give all of our treatment in about 5 minutes. And
now we have some other 5-day modalities. One is called, I'm reading this here, I didn't memorize it, stereotactic body radiation therapy. What's that all about?
The breast treatment is a catheter that we actually put into the breast, but we can also now deliver very high doses, very focused radiation treatments, much higher doses than we could safely give in the past. Like I told you, people aren't getting sick like they did 10 or 20 years ago because our computers are so smart, they can put the radiation in very safely. Well, we can also give much higher doses safely for small tumors. So one example is lung cancer. People are getting screening now. We're catching early little lung tumors, 1/2 inch in size. The patient may not be a good surgical candidate. They may be too old, or maybe they have diabetes or some other health issue, and the surgeon says, I think it's too risky to do surgery on your early lung cancer. But we can do this SBRT treatment, which is 5 days. It's not twice a day, it's once a day. And we're giving 5 or 6 weeks of radiation in 5 days. And it's very focused. It's through the skin using our treatment machine, the linear accelerator. We have fancy imagers. I was saying it's like Darth Vader. You know, we have all these arms that come out and take pictures and line them up straight. And then once they're in the perfect position, then they get this treatment. It can take about half an hour, but it's just 5 days. And we give 5 or 6 weeks of the way we used to give radiation. Now we can give it in a week. And the cure rate for early stage 1 lung cancer, 90% cure rate. So it's really amazing.
And for us guys, I understand there's a 5-day treatment for prostate cancer.
Correct. Prostate cancer as well. In the past, we had a couple options. We could put seeds into the prostate. We would put 80 or 90 radioactive seeds of iodine, this time iodine 125, and you'd walk around for a couple months while the seeds decay. And that was one option for early stage prostate cancer. We can do 8 weeks of radiation, Monday through Friday, which is a long course, and many patients don't really want to do the 8-week course. But for early stage prostate cancer, this 5-day course, stereotactic, you can give a very high dose in just 5 days. We're focusing it right on the prostate, so we don't hurt the area around the prostate. And again, this has been out for about 10 years now, and the data looks really, really good. And in fact, our national recommendations, it's called the NCCN guidelines, which is all the experts in the field now say this is an alternative to 8 weeks or to prostate seeds for early prostate cancer.
Now, is it possible for all cancers to be treated this way if it's caught early enough?
If you catch it early, I think yes, that's the beauty, is that you don't have to treat a big area around it. And if you can catch a small tumor, and we use stereotactic for brain tumors, which many times will catch small brain tumors, spinal tumors that many times we can diagnose very early and when they're very small. Yes, it's a wonderful tool for small early cancers.
Okay. Now, is this also more beneficial economically to the patient and the insurance company?
Well, radiation's expensive. Medical care is expensive.
Exactly, yeah.
So, I mean, stereotactic and 8 weeks of radiation, they're about the same.
Are they? Okay.
So if you can do it in 5 days and the patient's done quickly and it's convenient, I mean, so it's not like it's twice the cost, right. but it's an equal alternative.
Great. We're going to take a break. Come right back. Dr. Jeffrey Stephenson, radiation oncologist with the Montana Cancer Center, Providence St. Patrick Hospital. We'll be right back after this. And we're back on Health Talk, sponsored by Providence Health and Services, Western Montana. I'm Peter Christian, Dr. Jeffrey Stephenson, joining us here in studio. Now, let's talk for a second about the difference between radiation and chemotherapy. You say each one has its own, special way of working.
Yep, each one works differently, and they also work well together in many instances. Chemotherapy is a drug that goes in your vein, and it has to circulate through your body, and the cancer cell has to take up the chemotherapy. It has to get inside the cell. And once it gets inside the cell, some chemo drugs break DNA, just like radiation. Others turn off things in the cell. They'll turn off enzymes that help the cancer cell grow. So, and they'll pick the chemo drug depending on what kind of cells. So breast cancer chemotherapy may be very different from lung cancer chemotherapy because the cells are different and you need to attack them differently. Radiation doesn't need the blood. I shoot the radiation in through the skin, it goes in there, and it's more like a shotgun. I mean, it just kills the cell. I mean, I point it at the cancer cell and we shoot it in there and it kills it.
Doc Holliday.
Right. Doc Holliday. Yep, exactly.
All right. So go ahead. Come on, Scott.
I have a question.
Our boss, Scott Richmond, has a question.
Good.
Hey, how are you?
Good.
My dad actually had radiation. He had seeds to treat prostate cancer in the 80s. Mm-hmm. And I have two questions. One is, how has the technology changed over the last 30 years? Because I imagine it's changed significantly. Right. And the second, he was also issued a course of medication to help, I think, control the growth and things like that. How do they work in concert?
All right. with early stage prostate cancer, the prostate seeds, we still use them, and they're still a good option. It's a one-day treatment. You're asleep, and we put these 60 or 70 seeds into the prostate, and they stay in you forever. They give off radiation for a couple, 3 months, and then the radiation's gone. The radiation isn't given off anymore, and it does work. We have a 5-day course, which doesn't require surgery to put in, and a lot of men now are picking the 5-day course, the stereotactic treatment for early stage. You don't need hormone treatment if you're early stage, but if you're more advanced stage, then we will give radiation and hormone therapy together, and we have a much better cure rate if we do that. So again, it depends on your stage, and we have low risk, intermediate risk, and high risk. And like for high risk, the 5-day course isn't a good option. The seeds by themselves are not a good option either, and so you have to customize the treatment to the patient when they have more aggressive disease.
We have less than a minute to go, so we need to find out some contact information for you and the Cancer Center and how we get in touch if we have questions.
Online, we're mtcancer, no spaces, mtcancer.com, or our phone number's 329-5655, 329-5655.
You're welcome anytime, Doctor.
All right.
Thank you so much for coming. We appreciate it, and we're glad you're here in Western Montana.
Thanks.